Our webinar today will discuss radiotherapy for pediatric brain tumors and late effects of radiotherapy in children. My name is Jill Ann Demas. I'm the Senior Program Manager here at the American Brain Tumor Association, and I am delighted to introduce our speaker today, Dr. John Brenneman. John Brenneman is Professor Emeritus and Vice Chair of Radiation Oncology and Adjunct Professor of Neurosurgery at the University of Cincinnati and Cincinnati's Children's Hospital, Associate Director of the University of Cincinnati Brain Tumor Center, Co-Director of the Precision Radiotherapy Center, and serves on the American Board of Radiology as Chair of the Central Nervous System Committee. He will also be speaking at this year's ABTA Patient and Family Conference, which will be held July 25th through 26th in Chicago. Thank you so much for joining us, Dr. Brenneman. You may now begin your presentation.
Thank you, Jillian, and welcome everyone. Welcome everyone. Good afternoon. So we will be talking about radiotherapy for pediatric brain tumors and the late effects that they can cause. So radiotherapy is used to treat a large number of the tumors that we see in children. Astrocytomas, oligodendrogliomas, medulloblastomas, just to name a few. These are some of the more common ones, but this is just a partial list. And in many of the tumors that are treated with radiotherapy, radiotherapy is really an essential part of being able to cure these tumors. Now, we won't be talking specifically about different tumor types, but instead we're going to be approaching this in a more general way where we'll talk about how radiotherapy works. We're going to talk about how radiotherapy is given, some of the techniques that you might have heard of, things like 3D conformal and IMRT, and then about what a child actually experiences when we set them up and get them ready for radiotherapy and actually go through the treatment process. And then finally, we're going to be talking about what side effects of radiotherapy can occur in these children, and most importantly, what kinds of things can we do about that? How can we treat them or how can we prevent them? So radiotherapy is just one of the main anti-cancer treatments that we have. It's one of the triad of anti-cancer treatments, and the other two are chemotherapy and surgery. And radiotherapy in that group of three is really more like surgery than it is chemotherapy. It's a focal treatment. The effects of radiation are really limited to the area that we specifically target. And sometimes we can see effects of radiation that occur outside that area that are secondarily due to some of the things that happen within where we actually target, but it is like surgery. What we want to treat is where we actually aim the effect. It's not really, with a few exceptions, an ablative treatment. In other words, it doesn't actually destroy tissue directly like surgery does when surgery goes in and removes something. Its effects actually can be more modified so that we can have a different effect on tumor than we do on some of the normal tissue that we treat, and that's where its value really lies. We can use it in areas where surgery can't be used, where there might be a pretty large amount of normal tissue with just a few scattered tumor cells inside, and we don't want to take that whole normal area out because that would have a lot of bad side effects. But with radiotherapy, we can treat that small amount of tumor in a mostly normal treatment in a targeted way. Now, radiation is actually a generic term, and what it means is radiation is just a wave of energy or waves of energy. And there are lots of different kinds of radiation, but only a few of these we use in medicine for treatment of tumors. The kind that we use mostly in radiation therapy of tumors is called electromagnetic radiation. And there are actually many uses for electromagnetic radiation depending on how much energy that particular type of electromagnetic radiation has. And we encounter this type of radiation every single day in our daily lives. For example, in the lower energy side of electromagnetic radiation, it's radio waves or television waves. And as we get a little bit more energetic, we see microwave radiation, and then there's the visible light that we see with our eyes. Beyond that, the ultraviolet radiation, which is what causes sunburns. And then at that most energetic side of the spectrum are the X-ray or the X-rays and the gamma rays that we use for the treatment of tumors. Now I want to spend just a moment just orienting you to how we talk about how much radiation we use and how we look at radiation and how it appears in the body, because we'll have to use this as we talk about some of the other examples that we discuss later on. Radiation is measured in a unit that we call a gray. And some of you actually may have heard more a term called a rad. Rad is actually an older term that's been replaced by the gray, but there's a pretty direct conversion between the two. 1 gray is 100 rads. And some of us, even as radiation oncologists, we still like to use the term rads, and to make it a really direct conversion, we'll talk usually about centigrade, which is 100th of a gray, which just happens to be 1 rad. So you'll use those terms interchangeably, 1 rad and 1 gray. And to give an idea of how much radiation that is, how much is a rad or how much is a centigrade? Well, when you get a chest x-ray, you're getting about 1/50th of a rad or 1/50th of a centigrade. That is compared to what type or how much radiation we would use to treat a tumor, where typically we're using thousands of centigrade, thousands of rads. So there's several orders of magnitude in the difference between how much we use for things like taking x-rays and how much we use to kill and treat tumors. The other thing that is helpful to know is that we will use pictures like what you see here on the right called isodose curves. And these pictures show us what the distribution of the radiation is inside the body after we planned and aimed and directed it. And we represent that by colored lines. In this case, we have a target here that's sitting right at the bottom of the brain. And this targeted line here, this green line, is called an isodose line. What that means is that everything contained within that line contains at least as much or more radiation than what the color of that line represents. In this case, that colored line represents 30 gray or 3,000 centigrade. Here in the dark green line, everything contained within this line contains at least 25 gray. And we'll look at some examples of that as we go on. So when we use radiation, the target of the radiation and how it kills cells is through the DNA. And DNA is just a very complex molecule that provides the instructions for building cells and maintaining all the tissue that's in our body, including the normal organs and any tumor that might be present. And what happens when you use radiation is that radiation will interact with all sorts of chemicals inside the cell, and those interactions create chemicals or molecules that we call free radicals. And a free radical is just a very reactive chemical inside the cell. Anything it touches, it tends to react with, and in the cell, that is usually going to cause some kind of an injury. And it's the injury to the DNA that we're really interested in here. So when these free radicals interact with the DNA molecules, they cause injury or breaks in that DNA molecule, and that makes it not work well. Now, fortunately, there's a difference in the way that normal cells react to this injury than most tumor cells. And a lot of times, a normal cell, when it gets at least these smaller amounts of injury from these free radicals, will be able to repair itself. And those breaks in that DNA molecule will be able to be healed. Tumor cells do not heal that injury quite as well. And so that's how we can get a different effect in between normal cells and tumor cells. And we can actually use some things to exploit that difference and even magnify it, so we get great differences in what we do to the tumor and what we do to the normal cells. Now, when we deliver radiation to normal tissue, sometimes, as we've mentioned before, by design, because tumors can often have fingers that extend beyond what the actual tumor itself will look like and what we can see on a scan or an x-ray. And we want to have radiation distributed in the normal parts of the brain to help treat that. But sometimes we will actually then have to deliver radiation by necessity to get to that tumor. And there's a few different ways that happens. When the radiation comes in, it has to go through normal tissue oftentimes to get to the tumor. And then in most kinds of radiation, the radiation actually keeps going to some extent and exposes normal tissue there. We also have to build in margins of error around the target that we are aiming at, because we can't be exactly precise at where we're aiming. There's usually a few millimeters of difference of uncertainty in where that beam of radiation is being aimed and how the patient is being positioned that we have to take into account when we aim at these tumors. So we need strategies to protect normal tissue, because in radiotherapy, and especially in pediatric radiotherapy, it's imperative to protect that normal tissue as much as we possibly can. In children, the effects on normal tissue are magnified compared to adults because the DNA damage that the radiation causes is mostly going to be affecting growing tissue, which of course in children is the issue. So there are a couple of strategies, a few strategies in fact, that we use to protect normal tissue, and we're going to talk about the two main ones we use. One is called fractionation, which is where we take the radiation and instead of giving it all at once, we split it up into smaller doses and give it over time. And then the other thing we'll talk about is how we can maybe technically do a better job at getting that radiation to where we want it to be. How do we get that radiation shaped, and some of the technologies to focus the radiation just on where that tumor is. So as we speak about this fractionation, this is something that anyone who's had experience with radiotherapy probably knows, in that the radiation is given usually on a daily basis, often 5 times a week, and often over many weeks. Because from the standpoint of how the radiation affects cells, we know that the fewer the number of doses of radiation that we give, the more the radiation is going to affect the tumor and the normal tissue the same. And when we can get the same effect, we don't have that difference in protecting the normal tissue. So, and the way that works gets back to how we were talking about the way that the radiation damages DNA and how that normal tissue really repairs itself much better than the tumor in many cases. So for example, if we have a tumor that we're treating here on the first day of the week, on Monday, here's the tumor's DNA and here's the normal tissue's DNA on the left, and the radiation comes in and it's going to damage both that normal tissue and the tumor tissue. However, if we wait a period of time, several hours, a day or so, then what's going to happen in that period of time after that damage is done is that normal tissue then may be able to repair we're having a pause here. There we go. We're going to go back to this previous slide for just one moment. Okay, so that normal tissue now is repaired, but that tumor tissue just doesn't do as good of a job at doing that, and so that remains kind of broken. Maybe not enough to kill the cell at that point, but it's still broken. So then we do the same thing the next day, and on the next day, then we do the radiation again. At this point, the normal tissue is back to having intact DNA, but that tumor tissue still has that area that's injured, and now this additional radiation is going to cause more damage. And at some point then, that additional damage becomes something that that tumor cell can't tolerate, and it dies. And at that point, if we repeat that cycle enough times over many days or weeks, at some point then we hopefully are going to affect all of the cells in that tumor, and that tumor then is all going to be dead. All right, let's talk next about how we give radiation. What are some of the techniques that we use? So radiation, most of it is given by a device called a linear accelerator, and this is a device which generates electronically radiation, this electromagnetic radiation within this machine. The radiation can be directed out of this aperture or portal in the machine, and the patient lies on this table. Most of the machines now, the modern equipment, contains imaging panels like this so that we can take pictures of the area that we're treating in preparation and sometimes during treatment, and that helps improve our accuracy. Now, the way that these machines work is they're actually really fascinating, complex machines, and what happens is that initially we'll have a filament that just boils off electrons, and this is like the filament that might be in the back of an old television set that makes the picture in the back of those cathode ray tubes. Sometimes we use these electrons directly to treat a patient, but most of the time they can't reach far enough in the body to treat what we need to. So we take these electrons and they go into a waveguide where they're accelerated to very close to the speed of light. And in that wave tube, they get bent after their high speed, high energy, and they are then directed toward a target, and when those electrons hit this target, they make these high energy X-rays, or also called photons. And then those X-rays are directed out the portal of the machine toward the patient. At that portal, we also want to make sure that those beams of X-rays are shaped to the tumor so that they can be more accurate and focus where it needs to be. And for that, we use a device called an MLC, which stands for multi-leaf collimator. So if we look at what that is, kind of end on into the sort of the opening where the radiation comes out, that consists of a number of veins independently movable by computer, which can come in and out of the field of radiation, and they can just make different shapes of radiation to match the profile of the tumor from whatever direction that beam might be seeing that tumor. So by using that type of approach, we can combine a number of these beams that are shaped and make them all come in from different angles, each one delivering just a portion of the amount of radiation. For example, here in this lower dose purple area, but they can all converge on an area and create a high dose zone of radiation where we want that focus to be, where the tumor is. And this is called 3D conformal radiotherapy. That's a very useful technique for focusing the radiation on tumors which are fairly regular in size and shape, not too many curves in indentations. There's another technique which is really very valuable in the treatment of children with brain tumors, and that is intensity modulated radiotherapy, which is more often called IMRT. And IMRT is really useful because what it can do is create more complex shapes of these radiation zones. So here again in a tumor that's sitting at the bottom of the brain, we can create a shape of radiation around that tumor, but it's right next to the spinal cord, which is actually very sensitive to radiation, and we want to make sure we protect that. And IMRT can help us by carving that area out and sort of shrink wrapping the radiation around that irregularly shaped tumor. And the way that it does it, the way that we like to think about this is that it's kind of like a CAT scan in reverse. Because when you're getting a CAT scan, as many people have had experience with, what you have is you have a radiation source here that you shoot through a part of the body that you want to see. And there may be something in here, a tumor perhaps. As the radiation goes through, certain amounts of radiation are absorbed differently depending on where it goes through, and those amounts of radiation are registered on a detector which are combined with pictures made from different angles into a picture that we can then see. In IMRT, we actually start with the picture that we want to make inside the body. So we will take that same anatomy and we will create in here a picture that we want to make with the radiation. In this case, it's the tumor. We want to paint the radiation over that tumor. And then on the entry side where the radiation comes in, instead of giving just an even dose of radiation like what we've done here with a CAT scan, we change the amount of radiation or modulate it as it goes in so that as it goes through the tissue and combines with other beams, it actually makes that picture or that shape inside the body. And here's an example of what that can do for us. Again, this tumor located at the bottom of the brain, where on the left-hand side we have a treatment with these doses of radiation that we can create with 3D conformal radiation. And here we can treat the tumor, but we're also having to expose this normal spinal cord to a large amount of radiation, which we don't want. IMRT can really help us. It can carve that area out. And so this is a technique that's really used very, very frequently in the treatment of children with brain tumors. I briefly want to mention one other type of technique, and that is something called radiosurgery. Radiosurgery is the exception to that rule that I mentioned here where we talked about radiation not being an ablative treatment. Now, radiotherapy, when we use multiple doses, we do that so that we can get that difference in effect on the normal tissue and the tumor tissue. In radiosurgery, it's everything that we hit we want to kill, take no prisoners approach. So this uses usually only just one single treatment, very high doses, tightly focused on the area of the tumor that we might want to affect here. And there are a variety of different pieces of equipment and machines that do radiosurgery. Many people are familiar with the name Gamma Knife, which is the brand name of one of the radiosurgery devices. Radiosurgery can also be done by other devices. Linear accelerators can do that, as well as CyberKnife, which is a linear accelerator mounted on a robotic arm. But they all have the same intent, all the same plan, and that is to create these high doses of radiation very, very tightly focused around a tumor or something in the brain that we just want to kill. Everything within there we want to kill. And that is what radiosurgery is. So let's talk next just about what happens to a child when they're prepared for radiotherapy. What are the processes and the steps that they go through? Now, in almost all instances when we treat a child, or anyone really, with radiotherapy to the head, we are going to first make a mask of their head. And this mask does a couple of things. First of all, it keeps the person's head very still during treatment. And it also makes sure that we can get the patient's head in the same position every day that they come in for treatment. Sometimes all we need to do in children is make this mask, and that works well. In younger children, as you might imagine, this can be a scary thing. So sometimes in young children, we actually also use anesthesia. And anesthesia to put the child to sleep during the radiation isn't because the radiation hurts at all, because it doesn't. It doesn't have any sensation. But it's really just to make sure that we can keep the child still, which is what's necessary to accurately treat the tumor. Now, the process of making this face mask is one where we take this plastic material, which gets soft when it's warmed. So this is warmed in the water bath, and then it can be molded over the child's head and shaped around their nose and their chin. As you can see, it's got holes in it so that the child can see and of course, breathe out of that mask. And then as that mask is cooled down, it becomes more stiff and really very sturdy. After that is done, then we will get a CAT scan of the child with the mask in place and use that image combined with other imaging, often MR scans, PET scans, other imaging. And this is when the work of actually designing how the radiation treatment is going to be delivered is done. And we work together with a variety of other professionals, including physicists and medical professionals called dosimetrists, where the radiation oncologist will give the goals and the parameters of what the treatment needs to achieve. Things like what is the actual target, what are the areas that we need to avoid, how much radiation needs to get to different areas. And then the physicists and dosimetrists help in devising different plans or ways of achieving that. And this is an iterative process so that a plan will be evaluated and then changes will be made, and then another plan will be created and evaluated. And this whole process can take anywhere from a couple of days to sometimes a week or more. And this is what is called the treatment planning. The whole process itself is called simulation, and this is the treatment planning portion of it. The final step is to bring in the child for treatment, and the patient is positioned on the couch in the room where the linear accelerator is, and then the mask is put in place. There's imaging that's usually done to help position the patient so that they're in the correct position, and then the treatment at this point in most modern linear accelerators is really computer controlled, and the workings of the machine are done electronically. So let's now finish up by talking about side effects of radiotherapy. And this is really, I think, a very important part of treating children with brain tumors, because they're very susceptible to these side effects, much more so typically than in adults. And we talk about side effects often in terms of the kind of side effects that are early, that happen actually during or shortly after radiotherapy, and then the ones that happen later on. Now, the early side effects are actually usually pretty limited for treating with radiotherapy in the head in children. They include, probably the most obvious one is the hair loss, or the medical term for that being alopecia. But they can also include things like fatigue, tiredness, and some sleepiness afterwards, or somnolence, although children are, generally speaking, pretty immune to those types of things. The thing about early side effects is that they're usually reversible, that with the exception sometimes of some of the hair loss, these will all go away. So the things that we're really more concerned about are the delayed side effects, and these are things that may not happen for months and sometimes years. These are important because when they happen, they may not go away. They may be permanent. And we see these now in children with brain tumors more and more because the treatment for them has really been improving. There are a lot of children with a lot of these types of brain tumors are being cured and surviving long periods of time, so that their risk for developing these late effects is really growing a lot. Now, as we talk about these, there's a couple different ways we can kind of think about them and compartmentalize them, but we'll talk about them in terms of side effects. These delayed side effects we think are anatomic, and anatomic side effects are effects that we can see on a scan, that the scan looks abnormal. And then there's functional effects. And functional effects just mean that the brain isn't operating correctly. Something is not right there. And sometimes we can see these on scans, and there's a crossover between these two. But a lot of times these functional effects don't have any type of abnormality on the scans. But in terms of the anatomic effects, these are the ones, again, that we can see on the scans. There's a number of these, but these are probably the main ones. And the first one is called gliosis. And this is a picture of a child who had radiotherapy about 2 years prior to the scan being taken. And what we see here is an area right here that is too white. And this is called gliosis. And really, this is a scar. If this happened in another part of the body, we would recognize it as a scar. And when a scarring like this happens, it can affect the function of the brain in this area. And depending on what area the brain it is in, it can cause a variety of effects. Another way that radiation can cause a problem in the long term is through affecting the blood vessels of the brain, affecting the vasculature. And when that happens, it decreases the blood supply to the brain, and decreased blood supply is medically known as ischemia. This, in adults, when that happens, we would call a stroke. But in radiotherapy, if it causes just isolated injury, we can see these small areas of injury that look a lot like gliosis, but these are caused by lack of blood flow to these areas of the brain, and again can cause a variety of effects depending on where in the brain they occur. And then sort of the most serious effect is called necrosis. And necrosis just means that the tissue is dead. And a lot of times when people, even medical professionals, are talking about radiation effects in the brain after treatment, anything that we see on scans, we kind of lump into this term radiation necrosis, but that's not really accurate. Necrosis is when the tissue is actually dead. And that's important because some of these other types of things that we see, the gliosis and some of the other anatomic effects, you can reverse. But once the brain tissue is dead, once it's necrotic, it's irreversible. And that's why we reserve that term specifically for dead tissue as a result of radiation. So let's talk a little bit about functional effects now then. In functional effects, we have the things that control the motor parts of the body, the muscles, the things that make us be able to sense the sense of touch, hot and cold. Those things are actually very rarely affected except when there's some big anatomic effect in the part of the brain that controls that, some kind of area of necrosis. Much more commonly for these functional effects, we're going to see things that we would group either as neuroendocrine, which we'll talk just briefly about, or more commonly this cluster of effects that we lump into neurocognitive effects. And those neurocognitive effects are things like short-term memory, learning disabilities, trouble in school, what we would call executive functioning problems, being able to really put things together and function at a higher level. Just briefly, though, first about these neuroendocrine effects, endocrine refers to the creation of hormones, and there's a number of glands in the body that make hormones, the thyroid gland, the adrenal gland, but there are a couple of areas in the brain that are really important in hormone production, and one is the pituitary gland, which is located here at the bottom of the brain, and then another is in an area of the brain called the hypothalamus. And like I say, these make a variety of hormones that have an effect all over the body, and the effect of radiation on these areas of the brain is that they can decrease these hormone levels. Now, the nice thing about this, if there is a nice thing, is that most of these can be fixed. These hormones can be given and replaced so that those functions can be returned to normal. That's why in the scope of things we don't consider these to be necessarily as serious of effects as the ones that we'll be talking about here now. The cognitive effects, those are the ones which we are really more concerned about because these are the ones which oftentimes are permanent. And there's a lot of things that we've been able to find that really affect what the risk of that is. And how old is the patient? The younger they are, the more likely they are to have these effects of being able to think and process in memory. Radiation dose, as you might imagine, is important. The higher the dose, the more the effect can be. This fractionation effect, the more we can split up the radiation, the better. Coexisting medical conditions, not so much an issue when the child is treated, but later in life, if they develop things like high blood pressure or diabetes, those can cause additional injury on top of what maybe the radiation has done and sort of bring out some of these cognitive effects. And then just the location of the brain is also important in terms of what, where the radiation was delivered, what those effects might be. In general, we know a few things, though, about what radiation does. First, from the standpoint of when we use radiation to the whole brain. Now, this isn't really a terribly common thing that we do in treatment of children with brain tumors, although for conditions like medulloblastoma it does occur. But most of this information actually gained from children who were treated for leukemia, who required radiation as part of that treatment. And that we have learned that in a general sense, when we treat children who are very young, less than 3, they're usually pretty sensitive to doses of radiation that aren't very high from the standpoint of what we'd want to give for tumors. On the other hand, if we treat older patients, 18 years old and more, then we can often use higher doses of radiation and they won't show any adverse effects. But most of the radiotherapy that we use for children with brain tumors is what we would call partial brain radiotherapy, where there's just a specific area of the brain, in fact, that's being targeted. And here, there is more leeway in terms of what we can do without causing problems. And there's also been quite a bit of information coming out about this type of treatment. This is just one example of some information that was gained from children who were treated for either one of two types of tumors, a low-grade glioma or a tumor called a craniopharyngioma. And they were given radiation that was just directed to a part of the brain. And given quite a bit of radiation, this is 54 gray or 5,400 rad centigrade. 5 years after treatment, when they looked at how these children did on testing, either before and then after treatment, they would see that these children did not really have difficulties that they could measure. And that's not to say that individuals weren't affected, because there certainly are, but at least on the whole, when you averaged a lot of children together and looked at them, they didn't seem to have a lot of problems with that type of treatment. Well, what can we do about these side effects once they occur? And we'll talk a little bit first, I think, about this anatomic necrosis, the side effect, because that's one of the most serious ones that occurs, and that's one where a lot of work has been done to try and help that condition. Now, the tissue itself is actually dead, so that you can't necessarily bring that back to life, but you can help some of the surrounding tissue that may be just on the verge of being necrotic. So one of the things that we can do is to use drug therapy. And there's a couple of drugs that have been used extensively. A drug called Pentoxyfilline, otherwise known as Trental, combined with plain vitamin E. And this combination of drugs, when it's used outside of the brain, has been really effective in treating radiation that's injured other tumors and other parts of the body, or I mean other tissues and other parts of the body. It hasn't been studied quite as much in the brain, but it's used a lot just because it's such an easy treatment to give. And it works by helping blood flow get to the tumor better. Another type of treatment that's used is hyperbaric oxygen, and this is high-pressure oxygen delivered by having a child or a patient lie in a tank where that tank can be pressurized. This is a bit like fractionated radiotherapy. In order to be used, you have to do this on a repeated basis. So a person will usually spend 1 hour to 2 hours in a hyperbaric oxygen chamber on a daily basis for anywhere up to 2 to 3 months. This is the same kind of thing that divers might use if they have the bends, and sometimes it's also used to treat patients who have burns. But this forces oxygen into the injured brain tissue and it helps it heal. And then most recently, there's been a drug which has been extremely effective. This is called Avastin, or Bevacizumab. And this was really discovered by accident, because this is a drug that's actually used to treat certain kinds of brain tumors. And it was shown, or just observed, that when it was being used to treat brain tumors in children who had radiation injuries to their brain, that it actually helped the radiation. And again, it's been a very effective treatment. When we get away from just these anatomic necrosis types of things, these are actually the more common issues that we see, and those are those cognitive or functional problems, and what can we do about those? So there's some traditional things that have been used for quite a while, and these are things like speech therapy and occupational therapy, physical therapy sometimes if it's the motor function that's been affected. And then there are cognitive therapies. It's popular here on the radio, or these days I hear advertisements for brain exercises, and those in fact do help, do work. And then in children in school, special classroom assistance, types of things that might be given to children who have learning disabilities from other causes. There's a some very kind of interesting things that are being done experimentally. This is not something that's been used in people yet, but using a stem cell, a neural stem cell, to help these injuries heal. And a neural stem cell isn't like the stem cells that we often think of, these embryonal stem cells. These are just specific cells inside the brain that will be able to develop into other types of brain cells. And if a brain cell is injured, these can potentially replace them. And in fact, in animals, this has been tried. In animals, when they're given radiation and they're given enough to cause problems, you can measure how well they do on certain things like following through a maze. And after radiation, if they don't have any treatment, then they do more poorly on these tasks. But in experiments where they've been given these stem cells afterwards, they can actually improve their ability to perform those functions. Now, better than treating these side effects and these cognitive problems would be, how can we keep them from happening in the first place? And we'll talk just a bit about a few of these. The first one relates, again, to these stem cells. So we know where in the brain these stem cells live. They're in an area of the brain called the hippocampus, and there's the hippocampus is sitting on both sides of the brain here in this area. And in looking at how these areas of the brain respond to radiation in animal experiments, we know that when we treat these in animals, that's the part that really seems to have the most impact on their ability to learn and function afterwards. So now there are studies, and in fact some human studies that have been recently completed, that use radiation that specifically avoids these areas, and we're seeing now that when we do that, we can actually prevent some of those problems that occur later on with the cognitive function. Another technique being investigated is the fractionation again, getting back to that concept where the more we split the radiation up, the less effect we're going to have on normal tissue. So if 30 different fractions of radiation over 30 days is good, then maybe 50 over the same period is even better. So here is one study where they actually used that, where instead of giving one larger dose of radiation a day, they split it into 2 lesser doses of radiation each day and treated this disease, medulloblastoma, in children. And they found that when they looked at how these children did in school and on testing afterwards, that did seem to help improve things. One of the ways that radiation causes injury is by causing inflammation in the brain. And so drugs that prevent inflammation or treat inflammation, similar to things just like Motrin or Advil, have been used, at least in animal studies, to try and see if that will alter this injury that radiation can cause to this cognitive functioning. And it does seem to also have this effect in animals. We don't know yet how well it might work in humans, but since there are so many of these drugs available and they're used so widely, there are currently studies underway looking at those drugs to see if they may be able to help prevent some of these injuries. The last thing I want to speak about in this context here of what can we do to help prevent injury is something that has received a lot of attention in the press lately, mostly because it's such a promising modality for decreasing side effects, but also because it's such an expensive technology. This is proton therapy. Here are these pictures. This is actually the proton facility that's being built at Cincinnati Children's Hospital currently, the current status of this, and this will be completed in 3 years. But why are protons so exciting in terms of what they can do? And that really is a function of how they act in the body. So when we treat with X-rays, X-rays are shot in from the outside of the body, and they come in. Most of the energy that they have comes in at the entrance part of the beam of radiation, and it starts being absorbed by the body and then decreases as it goes through, hits the tumor, and then keeps on going. So this is where we want the radiation to be, but more radiation gets here and excess radiation gets here. With proton therapy, though, what will happen is that the nature of a proton is that it comes in at a low intensity of radiation, and we can actually make that radiation peak in its intensity as it gets just to the tumor. And then, rather than going out, bring it to a dead stop. So here, as opposed to the X-ray therapy, protons come in, deliver less radiation here, peak radiation dose here, and nothing here. So you can see very clearly how that might be advantageous in terms of sparing normal tissue the effects of the radiation. This is an example in this disease, medulloblastoma, of how that actually would look in a child. And in medulloblastoma, one of the areas of the body that has to be treated is the spine. Here is a cross-section of a child getting x-rays. Usually the x-rays are directed from the back, and they hit the area of the spine where we want them to be, but they keep on going. And here in cross-section, when they keep on going, the things that they're going into are the heart and the lungs and the esophagus, all things which we know can be damaged by radiation and cause problems later in life. In protons, they come in, they hit the area that we want them to hit, and then they stop. So there's no treatment, there's no radiation that's delivered to those organs. Now, these are very expensive propositions. These facilities will cost in the tens of millions of dollars. They consist of things like cyclotrons, which are large devices that actually generate the protons. This is a device that weighs about 80 or 90 tons. Then these protons have to be very precisely directed and focused using a series of magnets that often extend for hundreds of yards or hundreds of feet. These magnets, in fact, are made in the facility in Europe that created the equipment for the Large Hadron Super Collider. And then finally, before they get to the patient, they have to be directed around a device that can steer and shape them. Here is where the protons come out. Here is where the patient lies. To give you an idea of the scale of things, here's the technician who's working on actually building this gantry. But this is a very large device weighing, again, tens of tons. And one of the really remarkable things is that this has a very high precision. This can rotate and aim a beam of radiation with a precision of less than a millimeter. That then brings us to the end of our presentation. I'd be happy to entertain any questions.
Thank you so much. That was a wonderful presentation, and we do actually have a lot of questions already submitted. And just to remind people, if you have a question you'd like to ask, please type and submit it using the question box in the webinar control panel on the right-hand side of your screen. So I'll start with some of them that we had that were submitted during registration. Someone's asking about when do the effects of radiation on cognitive issues plateau? So do they continue to worsen over time, or is there a point where they stop and that is where the patient's going to be for, say, their lifetime?
Yes, a good question. They do at some point plateau, although that can be a period of years after the radiation is given. And part of that depends on the age of the child when the radiation is used, but there is usually a plateau.
Someone wanted to know, you mentioned vitamin E. How is that administered to help?
So the way that we do that is just as if you were taking it as a vitamin. And it's a capsule. In fact, when we have patients and children who use this, we have them go to the drugstore and buy it. And the dose that we're using for this, and again, this is usually done as part of a clinical trial at this point, since we don't have proof that it works, but we use a dose of 400 units twice a day.
Wow. Something as simple, you know, and as readily available as that. That's amazing. Okay, we have a question that was submitted here too. Neural stem cell transplants, are there prospects for this to be used in patients that are several years out, or does it have to be used more immediate of a treatment?
That we just don't know at this point. All of this work has been done in animals to date. And at this point, it's really immediate plans for clinical trials in adults. The issues surrounding stem cells and such, there's a lot of issues, both scientific and societal. And hopefully we'll get to that point, but at this time we just don't have that information.
Thank you. You mentioned brain exercises and that it works on younger children. Is there any specific ones that you could point these parents in the direction of doing? Is there, been studies of, programs, or is it just something they could pick up? What would you recommend?
Yeah, good question. What I will tell the parents of all the children that we treat, first thing is you just want to encourage things that involve active participation of the child rather than passive participation. And the very first thing that we do is tell them to turn the TV off. So that's something that if they sit there and just are passively involved in that for long periods of time, we know that that's not helping them at all. Instead, depending on the age of the child and what their abilities are, they can get involved in things like puzzles. If they're older, reading is a great activity to have. Even some of the video games that really require thinking and interaction, I think, can be a big help. This is an area where there's not a lot of information and really well-done studies yet, especially in children, but it's something that really does seem to make a difference.
Wow, if there's any children listening, you've given them permission to play video games, so let's be careful with that. But I do know, I understand the idea that, you do have to think and react quickly, so there are some good games out that they can use. Question about, in one of your slides, they're asking about Avastin. Is it for those who are already on Avastin as treatment, or is the Avastin used to help for patients who are not on Avastin as treatment?
Right. Avastin for this type of purpose is used on those who are not on it for other reasons. It's given specifically to treat that radiation injury. And again, when we use these types of things, we really like to point to data and information and studies. And there was just a tremendous study done with Avastin showing how well it works. This was a study where in patients who had this type of radiation effect afterwards, half of them were given Avastin and half were given a placebo. Everybody that got Avastin improved. Nobody that got the placebo did. And then they did what's called a crossover, where they took the people who initially got the placebo and didn't improve and gave them the Avastin, and then everybody that got the Avastin who'd gotten placebo first and didn't improve, then improved on the Avastin. So that's very compelling evidence that this is a really helpful drug for this. But it's usually given for specifically for the purposes of treating the radiation injury, although again it can be used for other types of brain tumors, specifically things like these higher grade gliomas.
Wow. Never heard of it used for something else. That's exciting purpose. What treatment options are there out there for radiation necrosis for these children?
So the necrosis is one of the big indications for the Avastin, and that's the thing that we tend to go to first now just because of its effectiveness. But the other thing that is used and has some effectiveness as well is the hyperbaric oxygen chambers. And that's a little bit harder because it does involve having to go into this chamber for periods of an hour or two over many, many days and weeks. And sometimes, of course, in smaller children, that's something that they can't do either because they're just cannot. It's just so frightening. Now, there are a few centers that have larger chambers, and we've had some children who will go in with their parents, and the parents will sit in them with them and read them stories during the time. But again, Avastin is just so much easier to use and actually more effective.
And I assume there's no harm to the parents going into the chamber?
Not most of the time. There are a few contraindications to that, and they involve things like if you have some certain types of lung disease or inner ear problems, sometimes then that's a contraindication to hyperbaric oxygen.
Wonderful. Someone is asking about radiosensitizer. Can they give it to children during radiotherapy?
Sure. So radiosensitizers are drugs that we know actually work together with radiation and magnify the effect of radiation. And the ones that really are most effective are the ones that actually magnify the radiation's effect more on the tumor than they do on any of the normal tissues that the radiation might hit. And there's a whole variety of these. A lot of them fall into the category of chemotherapy drugs. And we do use a number of these drugs together with radiation with the idea that they sensitize the tumor to the radiation and make it work better. One that's very popular in the treatment of brain tumors, probably more so than adults than children, is a drug called temozolomide or Temodar. That's used very commonly.
How about radiation as an appropriate treatment for tactile gliomas?
I think you're probably referring to tectal plate gliomas.
Okay, they just wrote tactile, so yeah,
Okay.
You're the expert, so you tell me.
I assume that that's probably what the question is directed toward.
Okay.
Tectal gliomas, this is a specific type of a tumor, glioma, which is actually a very common type of tumor, but this is even more specific in that it occurs in an area of the brain called the tectum. And there is something very peculiar about tectal gliomas, which we don't quite understand why, but these are often extremely indolent, benign tumors. The majority of children that we see with tectal gliomas, we don't do anything with. We just watch them because they tend to just stay as they are. Now, there are a few of these tumors that will grow, and in those instances, depending on the age of the child, we will either use chemotherapy initially, or if they're old enough that the side effects of radiation we think are manageable, then radiotherapy is usually an effective treatment for these.
There is someone who's asking about a patient that has had radiotherapy twice, 21 years apart. Wondering if it's cumulative, additive, is there any more brain development that happens, at that late, child, obviously older than 21, is there any more development that takes place after that time, or would the brain start deteriorating? That's obviously a lot, having radiotherapy twice in such, a short lifespan. What can they expect?
And these are a lot of great questions. So radiotherapy, once it's given, there is some ability of the brain to do some repair even in the years after it's given. And we use some rules of thumb. We usually think that maybe about half of the radiation amount that was given initially, if you wait sufficiently long, and by that a year or more, can be dealt with by the brain so that you can then give a repeat dose of radiation, perhaps not at the same initial level as you did initially, but at least it's something that should have some effect and still not have an excessive risk of having injury. The brain does continue to develop during childhood, but it does reach a peak usually at about the age of 7 or 8. And that actually coincides with the ages at which some of those side effects of radiation that we talked about with those functional effects and the effects on IQ testing start to really decline. So to answer that part of the question, yes, after about the age of 8, most of the development has occurred.
Okay, that's really helpful. Are you able to do neurocognitive testing before the children are treated?
We really try to do that with all of the children because it is helpful to have measurements of function, what they can do, and not just a general function, but specific tasks, things that they may have more trouble with afterwards that we can direct cognitive therapies and things toward. The other thing that becomes an issue there is that we know that the tumor itself, and then oftentimes these children will have surgery as an initial part of the treatment. These things can both also cause cognitive problems, and so these children often do have starting out with defects to begin with, that if we know what they are to begin with, then we can also have a little bit more accurate idea of maybe what additional burden the treatment itself that with radiotherapy or chemotherapy is given.
I'd love to hear that as a social worker, knowing that where they've started from and how close we can get them back to that point afterwards. So thank you for that. We have one more question before we kind of wrap up. It's a follow-up question. They're asking about the dosage of the radiosensitizer for children.
So, and that would be specific to the radiosensitizer that's used. If we're talking about, say, the drug Temodar or temozolomide, the typical dose that's used in conjunction with radiation is 75 milligrams per meter squared, and that's just a way of dosing that's sort of takes into account the patient's size and shape. If we look at how much actually body surface area they have, that often gives us a better way of dosing these types of drugs rather than just going strictly on weight.
Perfect. Well, that was almost perfect timing to wrap up our last question, and I appreciate that everyone online joined us, and especially Dr. Brenneman. We appreciate that you've spent this time with us today, and I'm going to pause for just a moment, and we are going to conclude our recording.